come on in. We'll have a few housekeeping things. We'll give folks a couple seconds to roll in. I see some more folks coming in today. So welcome to our latest session of AYA Power. Season three. I almost said season two, and that would have been a lie. We are in season three, which is pretty cool. Again, I'm Nick Galarakis. For those that don't know me, I'm the executive director of Elephants&tea. Today is discussions about goals of care and advanced care planning with adolescents and young adults with cancer with Dr. Jennifer Mack. And we'll get to her in a second, and Dr. Mike Roth will introduce her in a second. Just want to get some housekeeping things out of the way. Again, this is season three, and our theme for this season is moving forward with purpose. At a time when oncology and providers are navigating growing complexities, limiting resources, and widening gaps in care. This season invites participants to reflect on the challenges facing AYA cancer care today and to be part of shaping what comes next. Together with guidance from experts across disciplines, we'll explore how to move forward as a community committed to progress, equity, and better outcomes for AYAs. And we are delighted to be in our third to last session of the season. We have two more coming up following this one. Our next one's on May 7th on financial toxicity with Monica Bryant from Triage Cancer. And then our last to wrap up season three will be on June 18th on LGBTQIA plus cancer care with Scout and Charles Kamen. So more to come on that with those registration links. So we're excited for that. For those that have missed any of our past powers or want to refer back to it, as you're seeing Lisa on our team drop in the chat, you can check out all of our archive sessions on our AYA Power homepage. Those are always available. A couple housekeeping items for today. As always, please put questions into the Q&A area, and we'll read those off at the end and get to your questions then. So as they come up, please put them in. We'll be monitoring the chat, but it's far easier for us to be able to check things out within the Q&A area. Other than that, we're just excited to get going. I do want to thank our sponsors, I'm Not Done Yet Foundation and Eisai Pharmaceuticals, for supporting this important program and initiative to impact AYAs now and in the future. With that, I will pass it over to our partner in crime, Dr. Mike Roth. Mike, I will spotlight you and let you take it from here.
Thank you so much, Nick. And thanks to you, Lisa, Kayla, and others for doing such a great job leading all of these sessions and leading the curriculum as a whole. It's really been a great journey together. So we have a wonderful speaker today who did such a good job on a prior season that we invited her back again. This is such an important topic, focusing on goals of life, goals of care, and advanced care planning for our AYAs. And we do have the world expert here, not to put too much pressure on Dr. Mack. Brief background, not to be too long, but Dr. Mack received her medical degree from Harvard Medical School in 1998. She subsequently completed her residency in pediatrics and her fellowship in pediatric hematology oncology and pediatric palliative care at Children's Hospital Boston and Dana-Farber Cancer Institute. She also received a master's in public health from the Harvard School of Public Health. She is a professor of pediatrics, and her research interests are focused on parent-physician and patient-physician communication, optimizing healthcare quality, as well as palliative and supportive care. She is an international expert in end-of-life care for AYAs, and most importantly, Jenny's just a really kind and generous person, and we're so fortunate to have her back for this season. So, Dr. Mack, on that note, I will pass it over to you, and thank you so much for coming back.
Great. Thank you so much, Mike. I'll just share my slides here. I was reminded that last time I was here, I had no voice. I forgot about this. Are you seeing the presenter view or the regular view, the right
Sure.
view?
Perfect.
Okay, good. And so I'm glad that they invited me back because I was squeaking and cracking through the whole presentation last time. So good to see everyone, and thank you both for that nice introduction. I'll just go ahead and jump into this this topic. So this group probably knows well that there are now nearly 90,000 AYAs diagnosed with cancer in the United States each year. And cancer is the leading disease-related cause of death for AYAs. And really, this isn't a single subtype of cancer that's predominating, but cancer crosses a range of diagnoses. And there are rare tumors like sarcomas, there are early onset carcinomas like breast and colon, and just a wide range of scenarios for this population. And there's been work to emphasize the need for attention to medical and psychosocial needs at the end of life among these patients. But previously, the data has really been lacking on what their experiences are like at the end of life. And we need to understand what's happening in this population because they're different, as this group well knows. They experience illness at a time of emerging independence, a time when they're developing their personal identities and they're maturing in their relationships and becoming more identified often with peers than with their family. As their peers would be sort of looking forward in life and focusing on relationships, education, and employment, they're living lives that are different from those personal and societal expectations. And they lose independence, as you know, and that can have a major impact on how they cope with illness. So existing work prior to the work that we did on this study has identified high rates of medically intensive measures in AYAs at the end of life. And that includes things like late life hospitalizations, emergency room visits, care in the intensive care unit, late life chemotherapy. And these are in excess of rates that are seen in older adults. And that raises the concern that maybe this isn't the best care for patients. Maybe, these kinds of measures increase suffering and decrease quality of life at the end of life. But, we really didn't understand why this was the case. And it's possible that young people prefer more intensive measures, that this is the care they're seeking as they try to prolong life. So we undertook this study to try to understand discussions about goals of care and advanced care planning as an important prerequisite for end-of-life decision making. That if end-of-life communication and planning is inadequate or fails to meet the needs of AYAs, then that's one potential mechanism for high rates of medically intensive measures. And, I study communication. This is something I'm very interested in, but why is this important in this population? Well, work that was done more than a decade ago showed that AYAs have unmet needs for communication along multiple lines, communication about mental health, cancer in general, fertility, and they also have special vulnerabilities around communication. It's not uncommon for parents or other family members and also clinicians to want to protect them from difficult news. And so they may receive less information than other people in their lives do. And in addition, if AYAs are in visits with people like their parents or other family members, the needs of those caregivers might overshadow their own needs during consultations. I know I've seen this sometimes when I see young patients, that sometimes it's the parent who asks most of the questions. And it's hard to know what the young person is thinking or whether the visits met their needs unless we really try to explore that. At the same time, AYAs say they really want to be engaged in decisions about their own care, and that includes at the end of life. And so clinicians have to figure out how to balance these sort of complex needs of AYA patients and their family members. When we look at what's been done in adults with cancer, guidelines generally recommend advanced care planning for patients who have incurable cancer and a life expectancy of under a year. And they talk about different components that are important to include. There should be clear and consistent discussions about prognosis. There should be information about advanced directives and exploration of options around resuscitation. There should be introduction of palliative care options as well as hospice, and patients' preferences for location of death should be discussed. And I think this group may know this already, but why is this important? We know that understanding of prognosis and care options at the end of life influences the kind of choices that individuals make about how they want to spend their time and the care they want to receive. Adult patients who recognize they're dying, and this is the older adult population, usually don't want to pursue intensive measures, and they generally prefer to focus on quality of life if they know that their time is limited. Those who do receive more intensive medical care tend to have more suffering and poorer quality of life near death. And their surviving family members also have worse bereavement outcomes. The cost of care is higher. So there are multiple challenges that can result when we don't communicate about prognosis and planning for the end of life for adults. And then in addition, there's an important, it's not just about decisions, but it's about how people process this information. What kind of plans do they want to make for their personal future? How can they prepare emotionally for what's ahead? And if they have information that's not realistic, how do they feel later on about the decisions they've made about how to spend their lives? So we know that regret is common under those circumstances. We've previously looked at end-of-life discussions among adult patients with advanced cancer, again, older adults mostly. And we found that almost 3/4 have at least one discussion about end-of-life care before they die, but they seem to not happen in the most optimal circumstances. So more than half of these discussions occur in the inpatient setting, which means that they may be occurring during times of acute decompensation, such as, at admissions, rather than a planned, thoughtful discussion ahead of time. They also tend to occur with people other than oncologists. Only 27% of oncologists in this study had end-of-life discussions with their patients. And so that means that for patients who are relying on their oncologists who they know and trust and have known for a long time often to help guide them about the future, they may not get that. They may be having these conversations with people who they've just met at the time of an admission. And then those discussions tend to take place near death, about a month before death, at the median, which again gives them not enough time in many cases to really plan for how the rest of their life might unfold. We also know that adult patients who have earlier discussions about end-of-life care planning are less likely to receive chemotherapy at the very end of life and care in the hospital at the end of life. They're more likely to enroll in hospice, and they tend to enroll in hospice earlier, suggesting that there's some benefit to that earlier planning. So this study was aimed at bringing some of this knowledge into the AYA population. And we sought to understand the prevalence, the timing, and the outcomes of conversations about end-of-life care planning for AYAs with advanced cancer. And so here we looked at documented conversations that were documented in the medical record about topics like prognosis, goals of care, palliative care, hospice, and preferred location of death, and to assess relationships between conversations, goals of care, and the type of care that was received. This was part of a larger study, and the talk I gave last year also touched on parts of this study. This study was designed to examine quality of end-of-life care in AYA decedents. and to develop a novel set of end-of-life care quality measures that were suited to the needs of AYAs. And for this study, we reviewed medical records and electronic health data in AYAs who had died after a cancer diagnosis. We included almost 2,000 adolescents and young adults who were aged 12 to 39, and we'll talk about that age range in a minute, who died between 2003 and 2019 after receiving care in one of three sites: Dana-Farber Cancer Institute, which is where I work and is an academic cancer center, and then two Kaiser Permanente sites, Northern and Southern California. And those are integrated health plans and care delivery systems. So they provide the insurance and they provide the care, and they serve a diverse population across California. And again, we included young people between the ages of 12 and 39. And we did this really to be inclusive of existing definitions. I think many people here may know there are different definitions of AYA. Many people use 15 to 39. Some people go as low as age 12. And some people use kind of a narrower range of 15 to 29. And so we decided to cross that whole span. And as a pediatrician as well, I was interested in those younger adolescents and wanting to include them. They had to have been diagnosed with cancer at least 90 days before death. And we worked to include young people who had died an anticipated death, meaning that it wasn't an unexpected death due to treatment toxicity, but it was a death where end-of-life care planning might have been appropriate. And so to do that, we identified people with either stage 4 disease at diagnosis or stage 1 to 3 disease who had experienced a recurrence. And then we performed a chart review to make sure that there was a statement somewhere in the chart expressing that the patient was not expected to survive. And patients had to have been receiving care at the site at least 90 days before death. And we pulled data both from electronic clinical databases maintained by the Kaiser sites and also a separate clinical database for Dana-Farber. And then we used manual medical record review to capture additional elements. And again, we looked at documented conversations about prognosis, goals of care, palliative care, hospice, and preferred location of death. We looked at when those conversations took place. We looked at the presence and timing of advanced directives like do not resuscitate orders. And we used trained abstractors to pull information on these conversations. For each conversation, if a conversation happened on a unique date, we abstracted the information from that unique conversation. Because some patients, as you know, have multiple conversations about these issues. And we recorded the topics that were discussed and any preferences that were stated. So for example, we recorded, did a goals of care conversation take place? And if it did, what were the goals of care that were documented, if they were documented? And for goals of care conversations, because it can be challenging sometimes to abstract and categorize what those preferences really are, we abstracted the full statement on goals of care for review by the study team to make sure that we were consistent from site to site and reviewer and to reviewer in how we categorized these. And so for this study, goals were categorized as a preference for care focused on cure, a preference for care focused on living as long as possible, care focused on quality of life. It might also be called comfort, symptom management, or palliation, or an undecided preference when goals were elicited, but there wasn't a decision or a final statement about what the goals were. And then we also looked at care received because we felt that this was a potential outcome of discussions. And so here we looked at existing quality indicators for cancer care at the end of life. And this included things like chemotherapy in the last 2 weeks of life, 2 or more emergency room visits in the last month of life, being hospitalized in the last month, being in the ICU in the last month of life, using palliative care, using hospice, and the timing of hospice initiation, and then documented DNR orders before death. So these were the characteristics of the nearly 2,000 patients. Just over half were female, and 61% were white, 8% Black or African American, 12% Asian, and 27% Hispanic or Latino. There was also about 15% who didn't have documented race or ethnicity. And remember, this is from medical record data. So patients themselves may or may not have stated what they considered their race or ethnicity to be. The medical record data are not always accurate about categorization. And here you can see the primary cancer site. And, as I mentioned at the beginning, there are just so many different types of cancers that these patients experience. 14% sarcomas, 9% brain tumors, 14% breast cancers, 19% GI cancers, and so on. And about a third had stage 4 disease at diagnosis. The remainder had more limited stage disease but had a recurrence. So these were the discussions that we identified in the medical records, and this is the percentage of patients with documented discussions about each of these topics before the patient died. So we were surprised in a good way to see that most patients had discussions about prognosis and goals of care, more than 80%, and almost 80% had discussions about palliative care and hospice. And then about 2/3 had a discussion about their preferred place of death. We also looked at when these discussions happened. So for prognosis discussions, about 57% happened before the last month of life, and the median days before death was 39. So tending to happen, in that last 5 or 6 weeks of life. Goals of care discussions happened at a median of 43 days before death. Palliative care discussions, 58 days before death. Hospice discussions, right about a month. And discussions about preferred location of death, the median was about 2 weeks before death. We also found that younger AYAs, those who were 12 to 24, were less likely to have hospice discussions than older AYAs, but the rates were still high, 73% in that younger population versus 81% in the older population. And we were surprised to find that younger AYAs actually tended to have earlier discussions about prognosis, goals of care, hospice, and preferred location of death than the older AYAs. And it's important to note that we don't know who these discussions happened with. And so because the charts didn't always say that, so we weren't able to reliably abstract who actually had the discussions. And so it may be that with these younger AYAs, the discussions were happening with their parents or other caregivers, and that might explain why they tended to have these discussions earlier, but we don't know. In addition, we found different rates of discussions by race and ethnicity. Black patients had lower rates of discussions about goals of care, hospice, and location of death. And Hispanic patients had lower rates of discussions about goals of care and location of death. We did find that Hispanic patients more frequently had discussions about palliative care and hospice, which I would think of as a positive or potential positive for that group. But still, overall, this raises concern that, that clinicians are not as effectively identifying and understanding goals of care for Black and Hispanic patients, and this pattern has been seen in older adults as well. When we looked at documented preferences for care, first of all, we found that patients had a mean of 3 different documented discussions about goals of care. Remember, these were discussions that took place on different dates. So it wasn't just that multiple people documented the same conversation. And there was a median of 2 documented discussions per patient for those who had discussions. And the last documented goals of care in the chart, the goals documented closest to death, included living as long as possible for 6%, cure for 12%, palliation or care focused on quality of life, 69%, and 12% were undecided or didn't have an expressed preference. And then there were other preferences documented in the chart. 75% had a preference to forego CPR, 46% wanted to forego hospitalization, and 43% wanted to forego chemotherapy. Remember that more may have actually wanted to avoid chemotherapy or hospitalization, but these were cases where it was explicitly documented. And so here's how a little information about how preferences changed over time. So this first column is patients with only one discussion. So the patients in that category where there was only one documented discussion, 70% wanted to receive care focused on palliation or quality of life. But if we look at patients with more than one discussion, when we look at their first documented preference, 45% wanted cure-focused care, 18% wanted palliative care, and 28% were undecided. Then at their last documented preference, there was a strong shift to where 76% wanted care focused on palliation or quality of life, and 12% were undecided. So, these kind of multiple conversations, when they occur, seem to occur, with some evolution in the preferences that are being expressed. And here's another way to look at it. This is a Sankey diagram that shows how goals of care changed over the last 90 days of life. So the column to the far left is more than 2 months before death. And you can see that at the top, there's a small proportion of patients who had palliative preferences documented in the chart. Then in the light blue, those are patients who preferred life prolongation or cure. So larger proportion who have that documented in the chart, but the majority are in orange. There's nothing documented in the chart at that point in time. If you move over to the middle end of life period, and this is 31 to 60 days before death, you can see that there are a number of patients who have moved from having life prolonging or curative goals into the palliative goal category. And there are also a number of patients who've never had a discussion who moved into that palliative category. So palliative goals are growing. But so are other goals, life prolonging goals, and still about half of patients have had no discussion by that 31-day mark. And then once we get into the last month of life, that's shown on the far right. And more than half of patients are expressing palliative goals of care and have that documented. There still is a relatively large group of patients who have other goals. And then at the bottom, patients who never had a discussion are still shown in orange. And again, we found that as we look at these transitions over time, Black and Hispanic or Latino patients were more likely to stay in that group with no goals of care discussions over time. And that accounted for almost 20% of both groups, where compared with 12 to 14% of white or non-Hispanic Latino AYAs. Then we looked at the relationship between the last goals of care and the treatment that was received. And so you can see across the top, we have the different goals of care that were documented: prolonging life, cure, palliation or quality of life, and undecided. And then the column to the left shows these different aspects of end-of-life care: chemotherapy at the end of life, ICU care, ER visits, and hospitalizations. And I've highlighted this group who expressed palliative goals of care just to show you that while they had lower rates of many of these measures, still 11% received chemotherapy in the last 2 weeks of life. Almost a third received ICU care in the last month of life. A third received multiple ER visits in the last month of life, and 2/3 were hospitalized in the last month of life. And of course, we recognize that palliative care can be delivered in the hospital, but still it's a large proportion of young people who were hospitalized even with palliative goals. And then here we have these more palliative measures. So it's the same chart, but here we have palliative care referrals, hospice referrals, length of time in hospice, and presence of do not resuscitate orders. And here you can see that for patients who preferred palliation or quality of life, that was documented as their last goal of care. They had higher rates of palliative care and hospice referrals. They didn't tend to have higher, earlier use of hospice, and their do not resuscitate orders were also higher. And so even though they were receiving, I'll just go back, even though they were receiving a lot of these medically intensive measures, they were also receiving palliative measures. We also looked at the relationship between the timing of the first goals of care discussion. Again, this cutoff around 30 days. Did they have their discussion before the more than 30 days before death? And if they did, they were less likely to receive chemotherapy in the last month of life, in the last 2 weeks, sorry, less likely to receive ICU care, ER visits, and hospitalizations in the last month of life, although still high rates in this population. And then if they had their first goals of care discussion more than 30 days before death, they had no difference in rates of palliative care and hospice referrals. They did tend to have longer stays in hospice. And for reasons that aren't clear, their do not resuscitate orders were just a little lower when they had these earlier discussions. I would note, though, that sometimes it's hard to find do not resuscitate orders in charts, especially if patients went into hospice and had their had a MOLST form or POLST form done through hospice. It may not be in the chart, so that may be part of the reason for the difference. So I'll take a minute to summarize, and then I'd be glad to have some discussion. So, through this study, we found that even though many AYAs receive medically intensive measures at the end of life, it doesn't appear to be due to a lack of efforts at end-of-life care planning. I really, commend the clinicians who we studied here, in that most of the AYAs had conversations about prognosis, goals of care, palliative care, and hospice before they died. And many had multiple conversations about their care preferences over the final weeks or months of life. And so with all of that, about 2/3 ultimately expressed a preference for care focused on palliation and quality of life. But it took some time to get there. It raised the concern that medically intensive measures may not reflect preferences. So among patients who ultimately expressed palliative goals, nearly a third received ICU care and multiple ER visits in the last month of life, and 2/3 were hospitalized in the last month of life. And again, some of these measures, like hospitalizations, may be used to deliver effective palliative care. But the amount of ICU care and such, it makes me worry that not everyone is receiving care that's consistent with those frequent palliative goals. I think what was most notable to me is this intensity of care. And when we talk about intensity of care, we're often talking about medical interventions. But I think this is multidimensional. So it's not just an intensity of medical interventions like ICU care, but there's also an intensity of conversations, efforts at palliation and supportive care. And I think as a clinician, and maybe other clinicians here would feel the same way, this is kind of this feels familiar, that oftentimes when we have dying AYAs, the end of life period is very complex. There's physical and psychological distress. There are high medical needs, and there's a high intensity of need for communication and care planning, often repeated conversations to try to define the best path for individual patients. So, what can we do differently? I'm interested in your thoughts, but I'll tell you some of mine. Um, First, I think it's important that we prioritize goals of care conversations for all patients. By the time they died, 17% of patients had never had a documented discussion about goals of care. And, we know that documentation isn't perfect, but we also know that goals of care conversations are really important to document so that people can understand patients' preferences and it can cross encounters. So it raises the worry that, no matter what, those wishes aren't recognized or honored. It's also possible that some patients died suddenly and it felt like there wasn't time for this kind of conversation, but we worked hard to identify patients who had died anticipated deaths where end of life planning would have been the right thing to do or would have been appropriate, sorry. And so the vast majority of patients in our cohort should have been eligible for advanced care planning. In addition, if we're thinking about who gets left out of these conversations, we have to note that Black and Hispanic patients had lower rates of goals of care discussions. We don't know why this is the case, and we don't know whether this met personal preferences. But I'm a little worried that it doesn't, that it may reflect some bias. When we've looked at pediatric cancer communication, we found that physicians tend to underestimate wishes for prognostic information among Black and Hispanic patients much more than they do, parents, I'm sorry, than they do for white parents. And they also assume that Black and Hispanic parents have less understanding of medical information. And because of that, they tend to share less, even though we found that Black and Hispanic parents are just as likely as white parents to want prognostic information. And so I'm worried there could be a similar pattern happening here where clinicians are making decisions about communication based on inference or assumption, as opposed to just asking the patients if it would be okay to have this discussion. So, what I would say as a clinician and what I try to do myself is remember to offer conversations and give patients flexibility to decide what would be helpful and when. In addition, it's important to talk about these things early if we can. And because we saw that when discussions happened before the last month of life, patients were less likely to receive care in the ICU or the emergency room in the last month. They were less likely to be hospitalized. They had longer stays in hospice. And, it's easy for us to define early when we're looking back from death. It's not that easy to understand the timing, the right timing for the patient in front of you. I know that. But also, we and others have found that AYAs are interested in hearing about prognosis from the time of diagnosis. And they're open to palliative care conversations from diagnosis as well. So I think as clinicians, one of the things we want to do is just normalize conversations about the future and working together with patients, with families about how best to support their personal goals throughout care. And then my last recommendation here is to recognize that some patients are ambivalent. We had 12% of AYAs who had a goals of care conversation but didn't specify goals. And then they had no further goals of care conversations before death. And I think in my mind, this is an important finding. I think ambivalence is normal. This is a human thing for people who are facing the end of their life, and they have to figure out how they're going to approach it. And I think even more so for adolescents, ambivalence practically defines adolescence in many ways. It's a time of so much change and maturation and development of an identity. And so I think that, if we have patients who are not able to establish goals of care, we need to be sure we're offering them the resources and support, including psychosocial and spiritual support, to work through these challenges. And we need to go back and continue to have these conversations to support them as they do. So, of course, this study has important limitations. It was based on medical records and not what patients themselves said or, experienced. Medical records don't capture every conversation. They don't capture the content or quality of discussions. We don't know who was in the room. We don't even know whether conversations happened with the AYAs or their family members. We don't know how they felt about the conversations. And of course, we looked back from the time of death, even though clinicians make decisions in the moment, in real time, looking forward. So just to offer this last conclusion, here's what I take away, that most of the AYAs we studied had conversations about goals of care and advanced care planning, or their families did. Most expressed a preference for care focused on palliation by the end of their life. But medically intensive care was common despite this. And so ensuring that conversations happen with everyone, starting conversations early, and giving attention to those who are ambivalent, I think has at least some potential to ensure that care reflects patient preferences. This is my wonderful team of people who worked with me on this project, and I'll stop sharing so that we can have some discussion, I hope.
Thank you so much, Jenny. That was a wonderful talk. I think we all learned a ton. And despite the fact that I've heard you talk many times, I still learn new things every time. So thank you for a wonderful presentation. We have time for some questions. I have about 5 of them, but I want to make sure we go to the audience first. And Dr. Blyer, I'm glad you're on. So one of the themes of this year is, where are we going in the field? Where are we now? There's a lot of new changes politically in the healthcare landscape. And Dr. Blyer asks about the reversal of Medicaid dollars to support some of the financial resources, perhaps around end-of-life care. How do you think that is and may impact this type of care?
I think it's a great question, and it's an important one for us to try to figure out. I think that this population is particularly vulnerable around curbing Medicaid support. I don't have an exact answer to that. I think one of my excellent postdoctoral fellows is on Julia Stahl. And Julia recently wrote a paper looking at area level socioeconomic measures and how end of life care differed based on those measures, and found differences in hospice utilization based on area level socioeconomic measures. Not exactly a communication indicator, but another important way that we can support AYAs at the end of life. And something that we know is really differs by geography, both in terms of rural urban differences, but also for communities that have higher poverty levels, there often is lower access to hospice. So that's one piece that we know, but it would be great to try to understand more about how larger policy issues have impacted end of life discussion. So thanks, Dr. Blyer, for that question.
That's really helpful. Building on that question and comment, can you speak a little bit more about geography in terms of cancer care setting? So what's known or not known about treatment on the pediatric versus adult side, academic versus community site, high volume AYA site versus low AYA volume site?
Yeah, great question. And For this study, because we just had the three sites, we adjusted all our analyses by site, but we tried not to make too much of the differences that we saw. But we did see some differences, so for example, one of the sites was a high resource academic center. And so we saw, higher levels, particularly on the pediatric side of psychosocial care, for example, that wasn't always possible at all of the other centers. And we also saw higher uptake of early phase. I didn't present those data, but early phase drugs and other, targeted therapies, immunotherapy, we saw differences by site. And so again, there's this kind of funny thing where sometimes you get more supportive care and more intensive care, you just get more, and is care, which setting makes care better? It's hard to know, but there's a lot to learn still. And Mike, I know you're doing work in this area about the community setting, which is where most AYAs receive care. And so there's a lot more that needs to be learned, and hopefully you and your group will help to understand that as well.
That's really helpful. I'd encourage others, if you do have questions, please feel free to put them in the chat or the Q&A. I guess thinking about next steps. So clearly there are disparities and are challenges to delivering this care. Can you talk about kind of implementation science and cancer care delivery and either where research is going or at least needs to go and in what settings it would be kind of ideal to start and continue this work?
Yeah, that's great. I have sort of a couple of different answers to that question, and one piece is, as you bring up around the implementation science, which is kind of like we know what we should do, we're just not doing it, right? So how do we get ourselves to do it? And I'm a little bit less in that area, but it's crucial, for that we don't want delivery of supportive care interventions to be limited to the research setting, right? We want to get it into practice, and particularly appropriate for the community setting, thinking about how do we disseminate interventions, how do we make sure that best practice is really deliverable in a range of different settings. So that is crucial. The other thing that we're working on the next phase of this project, the renewal to the original grant. And what we're doing there is we also developed a set of patient-centered quality measures. So not just what does the chart say happened, but what does the patient say happened, and what do they really value, or how well did care meet their needs? So even for these communication measures, it was less about did you have a conversation about prognosis, for example, but more did you get the information you wanted, whether you wanted a lot or little or none? And so now we're using those measures in, we have 4 different centers that are prospectively assessing end-of-life care quality using those patient-centered measures. And we're working to enroll a more diverse population. We had reasonable diversity the first time around, but underrepresented Black patients in particular relative to the general population, and had these concerns about lower quality care. So that's what we're doing now in the follow-up is trying to learn, not just what happened, but how did patients feel about it.
That's really helpful. And I see you answered Maria's question about where are you going next. One of the questions in the Q&A is regarding EHR platforms, EHR tools, and to what extent can they fill some of this gap? I think many of us have kind of BPA fatigue, and a lot of things pop up and there's a lot of clicks that we have to do. But are you seeing progress in that? Do you think that is an area that can fill some holes and gaps?
I do think so. Actually, one of the other things that we'll explore at the end of this coming phase is whether we can use those patient reports about quality and integrate it into the medical record, so that if I'm taking care of a patient, again, coming back to prognosis conversations, for example, and they report that they just haven't gotten the information they need, then that comes to me as their clinician, and I can initiate that conversation. What is it that what should we talk about here around your prognosis? What would be helpful to understand, and try to work with them to meet the needs. So that's one piece. But also I think that, there is a role for different EHR-based triggers for these things. One of my colleagues at Dana-Farber, Chris Manns, has used EHR-based triggers in adults to identify patients who may be appropriate for an end-of-life discussion. And he's been able to increase, to some degree, not dramatically, but to some degree, the number of documented conversations, for instance. And so part of that is using data in the EHR to identify patients who are appropriate for these things. And part of it is reminding clinicians. But I agree with you, we have to be careful not to think that we're going to fix the world with reminders, or we're just going to live in a sea of reminders, and that's not going to help anybody.
Yeah, that's really helpful. And I'm glad that Dr. Hui is both on the call and also has a very valuable question because he leads our efforts here at MD Anderson. So he comments again on just how wonderful a presentation this was. And the question's about AYAs who preferred quality of life near the end of life. A third still were admitted to the ICU, as you mentioned. Were they preventable? And what are those kind of barriers and facilities that might be overcomable as we think about next steps?
Yeah, yeah, wonderful to see Dr. Hui on the call, my friend from study section, and who I admire so much. Yes, I really I of there's so many things that we have found through this study that are hard to see, and for me, one of the hardest is that, about a third of patients, as he notes, who preferred quality of life near the end of life, spent time in the ICU in the last month. And I suspect that that is partly because those preferences shifted or were discussed late in life, after care had already been, they had either were already in the ICU, or care had already moved in that direction. And I think we know as clinicians, sometimes it is that late life crisis that allows patients to think about these things or shift in their preferences, but also for me it just really calls for having those earlier discussions. I think it's a lot to expect patients, even people my age and older, to have one conversation and just know exactly what they want. And so I think especially for young people, we need to be having these conversations over time as much as we can. We need to make it just part of what we do. It's just a normal thing. It's not a crisis. I need to, I want to understand what you think about your care and what you want. And so that's what I think is probably what I hope might be able to prevent some of these down the line. But I'm interested in other ideas and thoughts from the group for sure.
Yeah, that's really helpful. And I know this area, not just for AYAs, but for the broader population, has been a big priority at our institution. And it's good to see this rise to the level of attention that it is needed, or at least start to rise to that level across more sites. We have time for one more question, and Emily will get the final word. Thoughts on simulations, conversation guides, preparing our physicians better to have these conversations, knowing the discomfort often that providers have, particularly if they don't have a lot of experience with end of life conversations, or perhaps more often treat a much older or much younger population.
Yeah, yeah, I think that's it's a great suggestion. And I haven't been as much of a communication education person, but it's really needed. I do think that simulations, role play, working with actors, that kind of thing can be very helpful. And other people have found that using guides like a checklist or a set of questions can be very helpful in increasing these conversations. And I do think part of it is really just increasing comfort with the conversations, helping clinicians to just have some simple tools of questions they can ask, and decreasing their own anxiety around this, because it is hard. And I think in some ways that's probably at the bottom of this problem, right? Is that this is so hard to do. And so making sure that people have the tools, that they get the training they need, I think is critical.
Yeah, I completely agree. And that's Jessica's comment as well. And that's part of the reason why we have these sessions, is to make sure folks know the importance and really spend time focusing on those needs that are most important to our AYAs. We're towards the end of the session. Jenny, you know how much I value and appreciate your work, and I'm hoping that there'll be opportunities to translate a lot of what you found into the community setting. I think there's opportunities with the NCI's Community Oncology Research Program to make sure that all AYAs are getting access to this care, which they deserve. And I think it's our responsibility to deliver this high quality care. On that note, if folks can please join me in thanking Dr. Mack, I'm going to hand it over to Nick to conclude this session and close us out. But Jenny, thank you so much for always being so kind and generous with your time.
Thank you so much for having me. Wonderful to see everybody.
Helps if I'm not muted. Jenny, Dr. Mack, thank you so much. That was wonderful. Dr. Roth, thank you as always too for moderating a great Q&A. And thank you all for attending today. As a reminder, if you could please fill out the evaluation that I will, or if Lisa is able to drop in that link for me, that'd be great. Woohoo, there it is. We'll email that out as well as the recording of this session and other sessions once it is available. We don't have the registration link up just quite yet for our next session, but as a reminder, on May 7th is going to be our next session, and that's going to be at 1 p.m. Eastern time on financial toxicity with Monica Bryant. So again, thank you all for being here today. Dr. Mack, thank you for a phenomenal presentation, and we hope you all have a wonderful rest of your day.
Thank you so much.
Take care.